guess that a muscle does. I know you've not done block 4 yet, but you can sort of guess that when you see where a muscle is, what it does. Like, it's obvious that the biceps there does something here, but the hippocampus doesn't look like a center for memory, so you can't guess what it does. You either know or you don't. So WMS phobia, yeah, that's one of them as well. Oh, okay. You must have found the face-to-face anatomy a walk in the park. Well, Richard tried to get me to help with there's another anatomist as well, a guy called Tom. He tried to get us to do like demonstration, unpaid, so we weren't happy with that. So that wasn't happening. But yeah, fun. Right, let's begin with stroke. I've procrastinated enough. So welcome to stroke. Now then, I made these slides for last year's physiology day, and I haven't looked at them since then. So let's hope I remember what a stroke is. That's great, isn't it? So learning outcomes, we're going to go through the different types of stroke. We're not going to go through brainstem strokes or cerebellar strokes. That's phase 2 specifically. We're going to go through a brief touch on the pathophysiology of stroke. We're going to describe the features of different types of stroke. And then we'll talk about how to diagnose them and how to manage them. So I'm going to keep the learning outcomes, I think I did, it was last year, keep them at the bottom of the page there. So you can, when you're looking back on this recording, you can say, okay, where is such and such a thing? And when we think about the circulation of the brain, you need to think about the difference between the anterior or the front and the posterior or the back circulation of the brain. Now, hopefully my cursor shows up here. You can see the aorta here. So there's the ascending thoracic aorta, then the arch of the aorta, and the descending thoracic aorta. There's several different branches: brachiocephalic, common carotid, left subclavian. Okay, so the anterior circulation of the brain, the portion that perfuses most of the brain, comes from this common carotid, which bifurcates into the external carotid, which supplies everything outside of the skull in the head and the neck, and the internal carotid, which is this green thing here, which goes through the base of the skull, does a weird wiggle thing that is very characteristic. It goes forward and then wiggles backwards, and then splits into the ACA, the anterior cerebral, or the middle cerebral. And so anterior circulation of the brain is ACA and MCA, and PCA, the posterior cerebral artery, comes from the vertebro-basilar circulation. Okay, so from the subclavians comes the vertebral artery. It runs up through these things called the foramen transversarium, which are the like holes in the cervical vertebrae at the side. It runs right up, and then it fuses to form a midline structure, the basilar artery. If you remember, you've got your midbrain, you've got your pons, and you've got your medulla. At the junction between the medulla and the pons, the vertebral artery fuses to form the basilar artery, and that's here. And then that also goes forward and wiggles backwards to form PCA. So that's basically it. You need to know the circle of Willis, which is every medical student's worst nightmare, but you need to know this. I cannot stress this enough. If you're watching this on the recording, this is where you press pause and draw it out. But what this illustration, which I really like, has done for you is it's color-coded the anterior and posterior circulation. So the lime and the tealy green color is the anterior circulation, and the purple is the posterior circulation. So just bear that in mind. And the circle of Willis just sits as a circle at the stalk. So if you think about the pituitary gland, it has a stalk that comes off it, that comes off the hypothalamus. And then the pituitary gland sits underneath like a bauble on a tree. And the circle of Willis drapes itself like a necklace around the pituitary stalk. So that's where it sits. And it's just by the optic tract here. So do make sure that for the exam, I know you've got months to go, but for the exam, you know the circle of Willis, because in previous years, they were asked to draw the circle of Willis. They were given the circle of Willis, and there was this pin in it. Which artery is this? Or there was a pin in it, and it would say, given your knowledge of which artery this is, which region does it supply? So it's very important that the circle of Willis is something that you become pretty familiar with. Okay? So when we talk about a stroke, particularly an arterial stroke, basically, you need to think about it as one of two things. So first of all, is it an infarct or a lack of blood supply to a structure, so a blockage in the pipes that means blood can't get there? Or is it a hemorrhage? So instead of there being a blockage, the pipe bursts open and blood accumulates. And if it's an infarct, we divide it based on the type of artery that's affected, right? So is it the anterior circulation or is it the posterior circulation? If it's the anterior circulation, that's about 60% of all strokes, and posterior circulation infarcts are about 25% of all strokes. Hemorrhage, on the flip side, intracerebral, meaning within the brain, or subarachnoid, meaning deep to the arachnoid mater of the meninges, within that subarachnoid space. Remember, you've got your meninges, you've got your three different things from anatomy. So you've got your pia mater, you've got your arachnoid mater, and you've got your dura mater. And the pia arachnoid interface opens up, and that forms the subarachnoid space where your CSF is. If you don't know that yet, don't worry about it. You'll get there when you do your Block 3 anatomy. So there's this thing you have to know called the Oxford classification of ischemic stroke, okay? And it's divided into 4 different types of stroke: a tax, a pax, a lax, or a pox. And what that stands for is a total anterior circulation syndrome or stroke, a partial anterior circulation syndrome or stroke, a lacuna circulation syndrome or stroke, and a posterior circulation syndrome or stroke. Tax, pax, lax, or pox. Now, how do you remember these things? Well, if it's anterior circulation, remember it's the internal carotid that does the wiggle forward and gives off the MCA or the ACA. And if it's the posterior circulation, it's the back of the brain, so it's the brain stem. It's the cerebellum, so that's phase 2, and it's the occipital region. So for phase 1, if it's a posterior circulation, you're going to get some weird brainstem stuff. You're going to get cerebellum signs, and everyone should know the mnemonic Danish. If you don't, post it in the chat and I'll mention what Danish is, because that's a mnemonic that tells you all of the different symptoms that come with a cerebellar defect. Any problems with the cerebellum, a tumor, demyelination, stroke, any kind of space-occupying lesion there, Danish is how it presents. But you're going to get visual things because it's the occipital lobe and it's phase 1, right? So so if it's a posterior circulation syndrome, you're going to get visual things. But how do you remember the difference between a tax, pax, lax, and pox? Well, actually, it's quite easy because if you know tax, you know pax, and you know lax. And let me explain it in some detail so you understand that. There are the 3 H's. The 3 H's of tax is hemiparesis and paresthesia. Okay, so hemiparesis is half-sided, one side of the body's weakness, or paresthesia, altered sensation. So one side of the body is paralyzed or has altered sensation. Homonymous hemianopia, so if we break down the etymology of what that means, homonymous means same-sided, hemi means half, anopsia means absence of vision, okay? So therefore, when you think about your visual field defects, it means that the defect is the same for each eye. So you either have defects on the left or you have defects on the right. That's a homonymous hemianopia. And then higher cerebral dysfunction. So those are the things at the top of the brain, the most complex structures, the last to develop evolutionarily because they're most superficial on the brain. So the reptilian brain is deep, and then evolution adds different layers and layers and layers. So the higher up we get to the brain, the more higher the cerebral processing, the more new it is. So the newer it is, the more likely it's something that humans can do that other species, particularly primates, can't do. So it's language, it's fluency of speech, it's thinking, it's processing complex things. So if you remember those 3, you've got tax. And why is that 2 for the price of 1? Because pax is a partial version of tax. So 2 or less of the 3 H's gives you a pax. So patient presents with hemiparesis and homonymous hemianopia, nothing else, it's a pax. Because it's all or nothing. You need the 3 H's. Patient presents with weakness on one side, a visual field defect that's a homonymous hemianopia, and they can't speak properly. It's a tax. Okay? So lax is even more specific because lax means lacuna infarcts, and the lacuna branches are deep penetrating branches of ACA and MCA, they're not for the higher up structures, they're for the deep lacunes, okay? They're right down here. That's an old anatomical term. And what does that mean? Well, that tells you that it uses the tax H's, but there is no higher cerebral thing because it can't get that high, right? So, and it also doesn't get high enough to affect the visual pathways. So it's a pure motor and sensory defect with no other tax, okay? And it's because they aren't involved with the higher cerebral things. So if you know your 3 H's, you know tax, you know pax, and you know lax. Just think of it as a scale going down for more concise and constricted defects. And POX is dead easy, because if a patient presents with an ischemic stroke that doesn't fit the H's, it's a POX, right? Because it's the different thing. So even if you don't learn anything else, a POX is everything else. So as soon as a patient presents with a stroke, you think to yourself for this exam, okay, does it fit any of the H's? Yes, it does. Right, then I know it's either a tax, pax, lax, or POX. If it doesn't, it has to be a POX before we learn anything else. Simple, right? Well, I say simple. But if you do want to remember the list, the mnemonic is back, because it's for the back of the brain. So because it's the brain stem where the left and right side of the brain's fibers come together like a funnel, you get bilateral motor and sensory loss because the brain stem is very thin. It's a very small diameter. So strokes will very easily affect more than one side. Okay, so it's very easy with a brainstem stroke to knock out both your motor and sensory. Homonymous hemianopia, again, because it's the back of the brain, you're going to hit the occipital lobe. Importantly for this, you will have a phenomena called macular sparing. So if you have a posterior cerebral artery, so this PCA infarct, the center of your visual field is retained, because by a weird fluke of evolution, the middle cerebral artery supplies the central zone. So you will retain a pinprick amount of vision, but you'll have constricted visual fields, as we say, because the whole outside has been infarcted. Okay, and then the C's are cranial nerve palsies, just like bilateral motor and sensory, because the cranial nerves come off the brainstem. If it's one side of this brainstem that's affected instead of both sides, you could have, instead of bilateral, you could have contralateral, but it's, to be honest with you, it's pretty common to be bilateral because I said the diameter is so narrow. And then the cerebellar signs, which is the Danish, which we can come to later if you want. So fantastic, there we go. We've cured stroke, we've solved it, we know everything there is to know about stroke. It's absolutely fantastic. If only that were the case. There's actually another way to classify stroke, because someone just came along and said, I don't think medicine's hard enough, you know what I mean? So here's the other way to classify stroke. We can classify it based on the syndrome of the artery affected, which means that this is why everyone has neurophobia, because it means you have to nail your neuroanatomy to be able to classify stroke. So what I would say to you, if you learn nothing else from this slide, learn tax, pax, lax, and pox, and learn this page, because this is so useful for you, and it will be useful in phase 1, 2, and 3. Will be so useful for you, and it's color coded. So ACA, this is a medial view of the brain, this is a lateral view of the brain. ACA comes out here, and this is where ACA originates. So it comes out and it runs over the corpus callosum along there, up, and then curls back. Okay, and that's actually really important because it tells you its distribution. So it supplies all of this bit of the brain, so it supplies this bit of the frontal lobe here, then it goes up here and supplies this bit of the parietal lobe, and it sneaks over the top. It grabs on, it sneaks over, and then goes laterally and just supplies this bit lateral here. The middle cerebral artery is different. The middle cerebral artery comes off near to ACA here, but instead of going forwards, it goes to the side. So it pops out of this lateral fissure of Sylvius here. It pops out of the brain, whoop, and then has an arcade that goes up and an arcade that goes down. And that's why the middle cerebral artery supplies the lateral aspect. And that's all you need to know, because everything else is PCA. So I always like to cut corners. Instead of learning 3 distribution territories, learn 2, and the third one is whatever's left. Okay, so what else do we need to know about this? Okay, this is the homunculus. You may have come across this in anatomy. This is how the sensory and motor cortex is topographically organized. So if I am, looking to see what my iPhone feels like here, like this, then the sensation will be information from the hand up to the brain. And the hand is represented here, which is about, if you look at the surface area, probably about a third of the way lateral from that structure there. Yeah, so that's what that is. So if you imagine, the way to remember this homunculus is, here's the corpus callosum, okay? That's the white fiber tract that separates the right and left hemispheres. If you imagine standing on the corpus callosum and just being exhausted from phase one and flopping forward, that's how it's organized. So you flop forward, you put your head forward like that, and your head falls off. And that's all you really need to remember the homunculus. Yeah, there's a bit about swallowing and stuff down there, but basically, if you stand on the corpus callosum, you flop forward. So here's your leg, here's your butt, here's your abdomen, here's your thorax, here's your upper limb, here's your hand, and there's your face. Now, why do I mention this? Well, think about color coding. ACA supplies this region, and MCA supplies this region. Remember we said that MCA goes laterally. This fissure here, where MCA pops out in the middle, is here. So it's going to pop out and run up to supply this region and run down to supply the temporal region. So what that means is, in a nutshell, and why I'm laboring this point a lot, this is an ACA territory. So ACA strokes, you now know, affect the lower limb and the trunk and a little bit of the upper limb, okay? Everything else is MCA territory. So if a patient presents with one-sided weakness and altered sensation in the lower limb and a weird sensation on the same side where the trunk is, you know that that's the ACA territory. So it's an ACA infarct. If the patient presents with a facial defect and an upper limb defect with sparing of the lower limb, it's not going to be an ACA territory. It can only be an MCA territory. So then you've gone ahead and localized it. And all I've thrown on here is just to show you what ACA actually looks like. So it gives off a couple of branches you don't need to know the name of, but wraps around the corpus callosum here. And this is the corpus callosum on my diagram. And that means that that is why ACA can supply these regions, because it's more medial. Okay? And then a little mnemonic that some people use, I can't claim this. This is a Tumblr account that used to exist, Medico Awesome from 2016. ACA looks like, the A of ACA looks like your legs, and that's how you can remember that the lower limb is supplied by ACA. If that helps you, it helps you. So I'm not going to go through this, but this summarizes in text what I just described for you. So make sure that you pause this and you add this to your notes when you come back to it. So I don't think this is in your year's lecture, so I'm just going to zip through this really quickly. But you do have a lecture on pathology where they talk, it might be later or you might have already had it, I'm not sure, where they talk about the different types of necrosis and when cells die, basically. And this is a really gross example of cells dying in the brain. This is called liquefactive necrosis, okay? So this is what happens in the brain. And there are 5 stages. If you don't have to learn this, just pay attention for mild interest. It starts with this thing called the red nucleus. And that's because eosinophils, which stain yellowy, orangey red on acidic dyes, hence eosin, which means orange, they come into the damaged area. They're the initial response of the innate immune system. By about 3 or 4 days, necrosis is starting to occur, and it's no longer red because neutrophils dominate and a lot of the eosinophils have left or died. By 3 or 5 days, then the microglia, a type of glial cell in the nervous system, proliferate in and start eating up all of the cellular debris. And then what you actually have is a period called reactive gliosis. That's where the glial cells cause inflammation and arteries proliferate into the structure. So you get a secondary appearance of red because there's so many capillaries being formed and little localized bleeding there. And then the final stage is a glial scar, where it scars over and it becomes a hardened appearance. Now, when I used to do dissection, we would use this to stage time of death in people who'd had hemorrhagic stroke. And that's why I bring this up. So if you had a patient that had a bright red case of bleeding with bright red nuclear degeneration of the neurons and the neuroglia, you could say, okay, this patient has died within about 12 or 24 hours because it hasn't progressed to the necrosis or the microglial invasion stage. So that's why I bring that up for you. So what are we going to do with these people? Because we've said what they look like, but what are we going to do with them? So we're going to use this thing called the medical model. I can't remember why I put fireworks there, but basically this is your stepwise approach to how you approach patients who present to you. So in phase 2, you're going to be given a presentation list of 76 presentations, just to make you nice and happy. And each presentation is the patient presents with difficulty swallowing. How do you work this patient up? Okay. And there's one called approach to the patient with a stroke. Okay. So you need to run a differential. What else could the stroke be? How do I take a focused history and how do I examine the stroke patient? What investigations do I order? How do I manage this patient? And what do I do for the follow-up? So the second half of this lecture is going to be concerned with how we deal with this patient. So when we think about the differential, it's either a CVA, a cerebrovascular accident, which is the posh term for a stroke, or it's a mimic of a stroke. It's something that could be a stroke. It presents like a stroke, but it's actually not a stroke. Okay, so it's important to ask focused questions in your history and look on your exam for the mimics of a stroke as well as a stroke. Because if you're blinded, or it's just a stroke, you might miss a brain tumor. Okay, so CVA, we've already described that as being a TAX, PAX, LAX, or a POX. It could also be something called a TIA, transient ischemic attack. Transient meaning it's a short-term thing. And a TIA is a TAX, PAX, LAX, or POX that fully resolves within 24 hours. Okay? It's what they used to call a mini stroke. When we had our phase 1 lecture on stroke, we had a neurologist who ranted for about 15 minutes about how there should be no such thing as a TIA, because a TIA is the canary in the coal mine to tell you that this patient is really in danger of having a stroke in the future. So treat a TIA like a stroke. Super serious. If you say it's a mini stroke, people go, oh, it's just a mini thing. I've survived, I'm fine. But no. So take it seriously is what I'm saying. And then we have this thing called stroke mimics. Now, stroke mimics, the mnemonic to remember stroke mimics is mimics. So I'm just going to go ahead and tell you what it is. So malignancy, it could be a brain tumor. Infection, is this something like meningitis or encephalitis? Is it a migraine with an aura? And that's really important, okay? So migraine auras are, people are classically diagnosed with a migraine aura and they're actually having a stroke. I'll just close the window, sorry about that. They're building an extension next door. Oh, of course it stops drilling as soon as I sit down. So insulin is the next one. So hypoglycemia is super important. So what we always say at the bedside is never forget glucose. Never forget glucose. When the patient presents with an altered level of consciousness, they're a 75-year-old male with a history of heart attacks who's had a stroke before, your framing bias and your jump will be to, this is a stroke. But just be careful because it could be a stroke mimic. Clot hematoma, have they fallen over and they're having a subdural hematoma? And seizure, okay? So are they having a focal seizure, which we're all experts in now after this morning, let me tell you. We all know everything about that. Now, the way that you sort of like, this is what a neurologist told me in, on a ward, a stroke ward last year, which I added because I thought it was a great quote. He said, mimics are normally slower onset and they have a lower GCS and everything's a bit vague. A stroke is a stroke. It's sudden onset. They're not vague symptoms. You can classify it into a TAX, PAX, LAX, or a POX pretty easily. And usually they're quite aware. Altered level of consciousness is actually a negative to, is this a stroke? It's less likely to be a stroke if they have an altered level of consciousness. Which is why strokes are so scary for the patients, because they're fully aware of this sudden onset weakness and facial droop and things, right? So you may have heard Public Health England's campaign a few years ago for the FAST test, face, arm, speech, time. Well, if you add the word be to it, so be fast, as in be quick to respond to this stroke, you actually get all of the focused questions you need to ask a patient who might be having a stroke. Okay, so BEFAST, balancing and bath. Okay, so are they feeling wobbly? Are they feeling sick? Eyes, do they have that homonymous hemianopia with or without the macular sparing? If it's with macular sparing, it's more likely to be PCA. If it's without, we're thinking that it's a TAX. Or a PAX, obviously. And then facial, motor, and sensory loss. And there's A is arms and legs, motor, sensory loss. S is for speech and swallowing. And then T is for a thunderclap headache. So the subarachnoid headache, the sudden onset bang. You hear thunderclap headache, and what a GP said to me, that what it actually is it's kind of like someone has taken a cricket bat and gone whack. It's a very sudden, specific area, bang, it hurts like hell, and it just comes out of nowhere. I think he actually said it's like a ghost hits you with a cricket bat. So the risks are, you can always break risks into modifiable and non-modifiable risk factors. What's something we can do, some things we can do something about and things we can't. We can't do much about the age of a patient, sadly, but we can control their blood pressure. Okay, so the classic phase 1 short answer question, I'm not sure if you still have short answer questions, but if you do, the classic phase 1 short answer question would be list 3 modifiable risk factors for stroke. And that's a pretty fair question, because they're basically saying stroke is one of the most common things ever in medicine. How can we modify the risk factors for it to make it less likely, right? So investigations, as we said this morning, there is a systematic way to always look at your investigations. Never shoot from the hip because you'll miss stuff. Bedside, bloods, imaging, and special. I didn't know what to put for special, so I put a starfish because I like marine stuff. So at the bedside, you're going to do an ECG and you're going to do glucose. You're going to do an ECG because arrhythmias make your blood wibbly wobbly and splashing about. And if you remember Virchow's triad from block 2, that's SHE, she, stasis, hypercoagulability, and endothelial cell dysfunction. Stasis is what we're particularly thinking about with an ECG, because if it's a poor pumpy of the heart, it's sloshing about. This is really scientific, isn't it? If it's sloshing about, it's static, it's whirling blood in there, it's not progressing on, and so it has a preponderance to clot. The other thing is glucose as well, as we said. So take the patient's blood glucose. You're going to do a full blood count and a white cell count. You think about infections, you think about anemias as potential things. And then you're going to do this thing called a CT and an MR head. Why are you going to do these? Well, there's a very specific, nice guideline criteria for this, and it's really long, but I'm going to break it down. It has to be done within 24 hours onset of symptoms. And the reason is that if you don't, brain tissue is gone. We talked about the necrosis period. At 24 plus hours, the neutrophils are coming in and they are eating up the dead neurons. It's too late. So there's no point exposing the patient's head to such an amount of radiation for a CT. So less than 24 hours with this emergency criteria, and that includes things like clotting issues. So are they making clots normally quite a lot? Okay, and if they are making clots quite a lot, then they're going to stand more chance of having a clot in the brain that causes a stroke, right? Really straightforward. Is their GCS deteriorating? So are they progressively getting worse and worse and worse? Well, that could be the sign of a massive hemorrhage that's pressing on the brain and pushing them down, down, down. It's rare, because hemorrhagic stroke, as we said before, is much rarer than an ischemic stroke, but it does occur. And if you're working in an ED rotation for 4 to 6 months, you might see one. Yeah, so any instance of you're thinking there might be a hemorrhage, you've absolutely got to do a CT head. And then, are you in the thrombolysis window? So this changes quite a bit, and it's a devolved issue. So CCGs can choose what the thrombolysis window is. This is the clot busting window. This is the window where the evidence says if you give a drug to bust the clot, bust the blockage that's causing the ischemia, the infarct, and you do that within a certain time window, there is enough time left to salvage brain tissue. Okay, and so that is anywhere between 4.5 to 6 hours, depending on what the CCG says. So if you encounter a patient in terms of the management who you think has a clinical diagnosis of stroke, you give ASA, which is aspirin, okay, acetylsalicylic acid. You're going to take them to the ED, and there's this thing called the Rosier scale. And the Rosier scale is what's used to rule out stroke in the emergency room. Okay, the FAST scan, face, arms, speech, time, that's what you will do pre-hospitally if you're a layperson. If you call 999, they will instruct you how to do that over the phone. So it will be, smile for me. Can you lift both arms above your head? Can you repeat this complete sentence for me? The quick brown fox jumped over the lazy dog's back, or something like that. Now, for the rule out stroke in the emergency room, my BFAST mnemonic covers Rosier. So if you remember BFAST, you've got Rosier. But do bear in mind that if the patient has a decreased level of consciousness or a seizure, it is a negative mark for your Rosier scale. Okay? So how we treat this now breaks up into two threads. Are they having an ischemic stroke or are they having a hemorrhagic stroke? So our CT is going to tell us which one they're having. So for ischemic stroke, is it in the thrombolysis window? If it is, you're going to give thrombolysis. And the thrombolysis to know is alteplase. So that's a recombinant tissue plasminogen activator, which activates plasminogen to plasmin, and plasmin breaks apart the fibrin bridges, if you think back to hemostasis, so it busts the clot. But if it's over 4.5 hours, we just give antiplatelet therapy. We just continue giving aspirin to prevent further platelet plugs forming, because we don't think that busting the clot has much benefit from that point on. Now for hemorrhagic, oh, and by the way, you need to make sure the patient's transferred to a level 1 stroke center. So the paramedics will be doing the FAST scan. They might even do some of the Rosier scans and ask some questions like that pre-hospitally, and they should, if they're querying a stroke, take the patient even further than the local emergency department if it takes them to a level 1 stroke center. That's because they have trained nurses and nurse practitioners and stroke fellows who have much better outcomes. And the evidence shows if you drive an extra 20 miles and it's an extra half an hour, they will have better care, even though it takes a little bit longer in the short term. So they'll have better outcomes. If it's a cerebellum or a brain stem hemorrhagic stroke, you go to neurosurgery and they evacuate the blood. But if it's a bleed into the brain, evidence shows that if neurosurgery goes in and takes that out, they have worse outcomes than if they did nothing. So we treat a cerebral hemorrhagic stroke conservatively with beta blockers and calcium channel blockers to lower blood pressure to prevent further hemorrhage, basically. And the clot just happens. So as you can tell, outcomes for hemorrhagic stroke are much worse than ischemic stroke. Not always, but usually. And then just a final slide about follow-up. And I'm not going to go through this because it's dead straightforward. You're modifying the risk factors, clotting, lipids, blood pressure. If they've got AF, treat it because the blood is sloshing around and is static. Stop smoking, exercise, better diet. Go into the how you want the rehabilitation services to help you. What are your needs and your requirements? Do you need things around the home for occupational health? And then do you need a carer needs assessment? Do you need carers to come in? Can we help with the funding of that? So that's my stroke lecture. Thanks to all of these resources that I think I used last year, but I can't remember. And of course, Dawn, lovely Dawn. That is stroke. Just to quickly remind you, my feedback form is different to the normal Neuro Soc one. So please do scan this QR code. Again, it's just the same feedback form